cornea part 2. Let's look at keratitis first. This can be infectious or non-infectious. Bacterial keratitis can be caused by gram-positive and gram-negative. Remember staph, strep, bacillus cereus, clostridium, and remember Pseudomonas, E. coli, Klebsiella proteus as you know to be your gram-negative and gram-positive. Most of these organisms require the epithelium of the cornea to be damaged beforehand so that they can enter and cause keratitis. But we have 3 extra dangerous organisms like Neisseria and Corynebacterium. They will enter your cornea even if it is intact. Bacterial keratitis has some stages in the pathogenesis. Billy ko pucho, IUR cat. Because there is progressive infiltration. Bacteria enters and with its adhesins and toxins it will adhere to the host cell receptors and the glycocalyx coat which will attract your PMS to your epithelium. There will be inflammation and necrosis. Now active ulceration. So there will be sloughing and necrosis of the epithelium basement membrane as well as a stroma and there will be hyperemia of the vessels. Purulent exudate will accumulate in the cornea. See a desmatocele, basically the protrusion of the descent membrane as a result of the damaged corneal stroma. Your infiltrated cells will also form hypopyon in the anterior chamber. Next up, regression. So because your body is responding with PMNs and inflammatory cells, there will be phagocytosis and necrotic material will be digested. And around the ulcer, we'll have a line of demarcation, so it is limited. Then we have superficial vascularization also. This is all regression phase. Fourth is cicatrice. Essentially means scar formation, so you have fibrous tissue being laid down. If your ulcer was superficial, you will have no scar. But more the involvement, progressively you will have nebula, macula and leucoma like I discussed in part 1. Patient will come to you with red PFP, typical bacterial keratitis, corneal symptoms, redness, epiphora and dimness of vision, increased watery discharge. Corneal pathology में pain होगा, foreign body sensation, photophobia also. Lids में you'll see varying degrees का blepharospasm. Ulcer floor may be necrotic. Margin will be swollen, overhanging and yellow-white in color. And around the ulcer, you'll have peri-ulcer stromal edema. In the conjunctiva, you'll see hyperemia, congestion. And patient has been having recurrent corneal ulcers. You'll do a sugar and a complete urine and stool test. Along with that, you'll try to rule out dacrocystitis. You have to assess the ulcer for its site, its shape. Also scrape the ulcer and send it for culture and AST. Scraping is done from the base and the edge of the ulcer with a modified chimera spatula or a 20 gauge needle. Obviously, before scraping, you'll have to apply some anesthetic, 2% xylocaine. If you suspect bacteria, you can do grams, GMSA, blood agar, and biochemical tests. You think it may be fungal. This if you have a fixed hypopyon or satellite lesions and feathery borders. We suspect Aspergillus, Fusarium, and Candida. Test you'll send for a STA, KOH, 10% mount, and calcofluor white stain. Antibiotics for bacterial, you can use CT or CV. If your bacterial ulcer patient has come to you, will give them ceftazoline. 5% reconstituted solution as 50 mg per ml eye drops. Ceftazoline along with tobramycin, which is fortified, 13.6 mg per ml, you'll give 1.3% solution. Eye drops to be instilled every 5 minutes for the first 30 minutes. After that, for the next 2 hours, every 15 minutes. For the next 2 days, you'll put it every 1 hour. After that, you'll give it 2 hourly during the day and 4 hourly during the night till the ulcer heals. And after the ulcer heals also, you'll give it every 4 to 6 hourly. Instead of CT, you can give vancomycin and ciprofloxacin or moxie also, because also 50 mg per ml 5% solution as eye drop. Cipromoxie is 0.3.5. Patient has a lot of pain when their pupils contract, so you will give cycloplegics, which keep the pupil paralyzed, 2% homatropine 1 drop BD or 1% atropine sulfate 1 drop TDA. Pain ke liye also ibuprofen and paracetamol, and you will give goggles and protection and fomentation also. For fungal and candida, you can use amphotericin B or Nistat. For the filamentous fungi, you can use natamycin 5% or amphotericin B 0.15 or miconazole 1%. Voriconazole also for aspergillus. Give it hourly and then taper it gradually. Only if drop fails, then you will give penetrating keratoplasty.